I'm going to talk about not trauma, and don't leave now, all trauma surgeons. We're going to talk about total hip arthroplasty and what happened from registries in the past 30 years. Oops, sorry, we need to find out here. Use this guy. Not, okay. Disclosure is mandatory for US surgeons, especially those based in Massachusetts, and this is my disclosures, has really nothing to do with the talk. Evidence-based medicine and patient-derived outcomes assessment started in 80s and 90s. In the late 80s, mid-90s, critical research suggested that 40% of the surgical procedures we do are inappropriate, and up to 85% of common medical treatments are not adequately validated. The efficiency of a medical intervention must be based on scientific evidence. We are all obliged to build the clinical treatment on evidence-based principles. How do you generate evidence? Especially, how do you do it in total joint replacement? Randomized clinical trials are difficult. It takes time, it takes enormous amount of patients, and it's been not used very much. Observational studies or registries is the tool to use to create evidence. Registry milestones and innovators. Mark Coventry started what they call the Mayo database. It is a registry in 1969. Lars Lidgren, the Swedish knee, in 1976. And Peter Herbers, my mentor in my Gothenburg time, and a close friend, the Swedish hip, in 1978. And those two last were both inspired by Goran Bauer. And I've decided yesterday, to look at two critical questions. What is the current evidence on implant fixation? What is the current evidence on bearing surfaces? And, of course, go to the Swedish registry. And you can go there yourself and find every slide I'm showing you tonight because I downloaded them yesterday. The baseline data you need, what we call level 1 data, I'm talking more about that tomorrow, are very simple, and you can find them in any medical record. You don't need physician compliance to make this work in any field in orthopedics. And the mission is, of course, to improve the outcome of the total hip replacements. It's a quality control system with focus on the procedure, not an implant registry. And the hypothesis is that feeding back the data will stimulate the participating surgeon to improve their practice in accordance with principle of the good example. And the internet has substantially facilitated feedback of information. This is the amount of data that's in the most recent report from the Swedish registry, 300,000 primary hip, 30,000 revision hips. And this is really the summary, the result. These are patients done between 79 and 91. National average outcome was 89.4% free of revision. And this is the improvement looking at the cohort 92 to 2004. So the register has impact on the outcome of surgery as such. Looking into the epidemiology of total hip replacement in Sweden, you can see the red area here, they are cemented. Northern Europe have a tradition for cementing. And the reason is the good outcome of cemented technique. You can see the uncemented hips have a much higher, the red bars in the bottom, much higher proportion of their implants going to early revision. And this is one of the reasons for this, that the polyethylene is not working appropriately. There was improper cup designs. The yellow curve denotes the survival of a cup, uncemented cup. If you look at the Swedish results today then, in the most challenging group, patients younger than 50 years, there's still a superior outcome in the patients with all implants. This is what these two curves are illustrating. I don't go into the details as such. If you look at this slide, you can see the blue and yellow curve on top are cemented and hybrid implants. The red is uncemented. The green is reverse hybrid. For some reason that become very popular. And the black one is resurfacing, the most modern, most expensive, and most fantastic bearing. So, if you look at this slide then, what is going on in Sweden? Despite the good outcome of cemented implants, the surgeons are not using it. Why? Norwegian registry, this is the web address, you can go in and look up everything I show you. They have exactly the same finding, that cemented even here subdivided into 2-year span over the time. Your slide shows the outcome of cemented. You can see it's superior to the uncemented, and the Norwegian registry is more sophisticated. There is adjusted for gender and for age. Still, cemented comes out on top. And the 2 leaders of the Norwegian registry conclude there's considerable evidence from our registry studies that cemented implants, both in the femur and acetabulum, give satisfactory long-term results. These findings applies for both young and old patients and for all diagnostic groups. What happens in Norway? They stop using cement. You can see the dark green is cemented and how it's declined from 2003 to 2009. UK, another traditional cementing country. Implant survival, blue, top curve, cemented. The green, red, cementless, and yellow, hip resurfacing. Exactly like the Swedish registry. What happens in UK? They stop using cement. Why? Oh, no, the Australian registry as well. The green bars and the most to the left is all Australia, or you can see the green, the cemented proportion disappears in favor for the cementless. If you look at the results, the cumulative % revision, adjusted for age and gender, the top curve, the blue one here, is cementless, having most revisions, and significant more revisions the first 2 years after surgery, as compared to the green and the yellow, cemented and hybrid. So in all 4 countries, superior of all cemented total hip. In all 4 countries, significant decrease in use of all cemented in the past 6 to 8 years. Okay, alternative way to create evidence is to combine randomized clinical trials and observational studies in what is called a meta-analysis. We published a paper in Act Orthopedica 2007, comparison of cemented and uncemented fixation in total hip replacement. And the gold standard could still be considered the cemented fixation, based on long-term results in the Swedish-Norwegian registry, based on the Shani results from worldwide. Cementless fixation, there were studies showing improved survival with the porous incoat, the modern configuration of the uncemented implants. And I even concluded in a report from the Swedish registry that there might be survival advantage over fully cemented in younger, more active patients. What do you do when you do a meta-analysis? You develop a research question, and then you search available databases. You select your papers based on research question, and you do a pooled analysis of the data, and the heterogeneity is investigated with subgroup analysis and meta-regression. We looked at any patient with osteoarthritis of the hip joint that got a total hip replacement, and in the paper should be cement versus cementless fixation, and the outcome was survival to revision. And it was randomized clinical trials and observational studies. We reviewed 747 papers and found 20 control studies we could use. This is 4 years back. The meta-regression shows this. When that line crossing the slide is below 0, then cemented is advantageous, and when it's above 0, cement. And the conclusion is that neither fixation method shows significant benefit based on pooling or controlled studies to date. Cemented fixation shows superior survival among studies inclusive of all ages, defining failure as revision of either or both components, and cementless fixation showing improved survival versus cementing in more recent years among studies defining failure as that of a specific component. That's really picking up the problems with the polyethylene. What about bearing surfaces in total hip? What should we use, metal or ceramic on polyethylene? Should it be highly cross-linked or not? Metal on metal, and what head size? Ceramic, ceramic, or there's even somebody coming with ceramic on metal now. Looking back in the Australian registry, conventional versus resurfacing, the higher the curve, the worse the outcome. The high curve there, the green one, is resurfacing. and it's significant worse than conventional throughout the whole observation period. Looking at resurfacing by age, the red curve, patients more than 75, bad outcome. Looking by gender, the blue curve, female, significant worse than male. Resurfacing by head size, then, is the latest and reported in the acta you got in your bag when you registered for the Congress. So you can see the cutoff, less than 44, the green, 45 to 49, the blue, 50 to 54 is the yellow, and more than 55 is the red curve. So it's not really gender, it's the head size that determines the outcome of a resurfacing procedure, based on the Australian registry that have most on that procedure as such. Looking then in the England's Wales report, revision rate, you can see RSR, 7.5%, and this is 4-year follow-up in the England registry, conserves 7.4. How can we have implants that 4 years after introduction, 7.5% has been revised? We know the background for this is soft tissue reaction, alveolar pseudotumors, the bad outcome of revising the resurfacing patients. We need to be restrictive using this in smaller patients. And I'm not big enough for resurfacing. I measured my femoral head. Implant brand seems very important. That important. So if you look then in general on the bearing surfaces in Australia, we don't have all the details we need, but we can still here see that metal, the yellow curve, are significant worse than metal on polyethylene. All head sizes, all types of polyethylene as such. If you go to heads larger than 28, which means 32, 36 and beyond, that discrepancy, the difference between the metal and the conventional metal polyethylene get even more pronounced based on the Australian data. This has led to the data from the English and from the Australian registry that J&J or DePuy few days ago recalled their ASR in all configurations, and they're now offering all patients paying all revision costs associated to use of that implant, which is going to be several $1 billion to do that. Why do we do this? 2010. There are limitations in the registry information in a lot of senses. At bearing surfaces, there's no information on type of polyethylene, there's no information on type of ceramic bearing, and several more. I will meet with the leaders for the Australian registry in a few weeks in Glasgow, and we have agreed now to try to compile information from several registries and get a publication out on that. So how do we, as physicians, determine the optimal treatment for the individual patient? How should new technology be monitored? And I have to thank Dr. Dennis Burke, one of my colleagues in Boston, for some of these slides. What motivates the surgeon to adopt new technology? Do I want to do the best I can do for my patients, or are there temptations with new fancy stuff and industry influence? Clinical benefit is the most noble of all. Competition among surgeons, I want to have the latest and greatest, and the patients are out looking at the internet what that is. Consumer demand and manufacturers' advertising incentives. Computer-assisted navigation for knee replacement. Why not? Because misalignment is associated with a higher failure rate. But if, in year 2030, where the predicted number of total knees in the US will be 3.5 million, if we put a price on navigation, $1,000 for each, that would cost $3.5 billion just in navigation costs. And we have actually showed in a recent paper in the American Journal that it doesn't really help anything doing this. The total gender war, and how a very famous surgeon
that they've had anterior knee discomfort their whole life. Their knees have always bothered them. And so they're hoping that the new knee will solve that, which previous total knees didn't do quite as thoroughly perhaps as we like.
I don't think I don't know how to show the next video. We will drop it.
Many women are aware.
Sorry.
Many women.
If you're thinking about a
Here
knee
we are.
replacement,
This is a company
Stryker is a
advertising
revolutionary
direct to
new
the
knee
patients.
designed with women like Barbara in mind. You'll be surprised how far it may take you.
So this patient can walk through all Manhattan with her new gender knee. Isn't it fantastic? Famous people hips. Jack Nicklaus, Jimmy Connors, Milo Retton, gold medalist in gymnastics, Floyd, what was his last name? Doesn't matter. He was, for a few days, a Tour de France winner, but they realized it was not real. So what are our patients doing?
Yes! 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 Oh! Yes! 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 I'll have what she's having.
Sure. You can pass on. It's always different videos. This is Floyd Landis' official web page where he advertised for Metal and are still a competitive biker. So we need something to modify this. Michael Gross, in 1993, proposed phased clinical trials for innovation in surgery. There's an urgent need for the stage-controlled introduction of new technology and new procedures to surgery. I made my own thesis around the need for a stepwise introduction of new technology, where you do preclinical testing, where you randomize trial and use the methods you can use there is RSA, highly sensitive evaluation tools. You continue to center study. When you're safe there, then you can introduce it to a wider surgical or clinical community. And of course, monitor in registries. You can see how much we have learned of those 4 registries I've just shown examples of. And just one study here that we did many years ago looking at a new bone cement that should be the most fantastic ever developed. We did 30 hips here in Gothenburg. Jonas Tanner, who is here in the audience. We found out after 3 months there's something wrong with the new cement, was, as usual, blamed by the company, your bad surgeons. There was a lot of bad Norwegian surgeons as well, but they could show, based on 1,300 patients in the Norwegian registry, this cement is not working. And then they gave in the company and recalled the cement or withdrew it from the market. But more than 50,000 patients got this cement completely unnecessary. American healthcare, 2007, the spending per man, woman, and child is $5,400 as opposed to $2,000 in England. An enormous amount of money for healthcare spending. If you look at life expectancy, US is number 47, so they can probably use their money in a better way by spending it all on technology. Medicare budget explodes now. The predicted cost for next year is $550 billion. There are problems doing this stepwise algorithm, following it. The time factor, it takes 8 to 10 years from you get the good idea to you really can use your product on all patients. Should it be mandatory or it should be voluntary? Who decides when you need, due to design changes, to set up a kind of baseline evaluation of an implant? And then there's been a lot of difficulty using the best tools in orthopedics in US due to the FDA. And who is responsible for doing this? Is that the producer? Is that the marketing organization? Is it the health authorities? Or is it us, the surgeons? But if we say no, when they come with a new metal or metal ceramic implant, if we say no to that, then it won't get into the patients. So it's probably ultimately our responsibility to do this. And we have actually just got a paper accepted on the stepwise principle as such, but there is a lot of dilemmas, because if you have a good technology that will benefit a lot of patients, you will also delay the introduction of that new technology. So sure, there's a lot of problems created with this. So what have we learned? That was the question we started asking in the past 30 years with respect to primary total hip. I would say not enough if you look what's happened in the past 5. The registries can facilitate outcome improvement when the orthopedic community is compliant. You need to have the surgeon's ears. They need to believe in what the registry findings is. And that's happened, I would say, in Sweden, Norway, and Denmark, definitely. It can provide critical information on outcome and identify a lot of problems, but no solutions. So parallel to running your registry, you need as well to set up conventional clinical trials, preferable multicentric. We need more registries, and of course that we should be more critical and more skeptical whenever we are facing new technology. Each country, or at least region, needs a registry. We can't use the Swedish data and extrapolate that to Italy. You need to collect your own data because outside of implant performance, you do actually measure a lot of surgical performance. And I'm talking much more about that tomorrow afternoon in another lecture. Thank you.